Hello, I want to welcome everyone back to our community conversations. I'm Bryan Daniels with the Blount Partnership. I want to welcome today our guest is Don Heinemann. He is the President and CEO of the Blount Memorial Hospital and has done a great job for our community. And Don, you're no stranger to the leadership role with the hospital. You've been there several years, haven't you?
Yes, I started right out of graduate school in 1985, so I'm in my 35th year.
Wow. Well, appreciate you making time and joining us today.
Appreciate you having us. I've noticed through the whole crisis that we've been going through that I think the chamber's really been stepping up and really showing great leadership with the communication and resources that you're keeping everybody up to speed on, or get those daily emails and with things going on. And I appreciate the leadership that the chamber has taken, or the partnership has taken through this crisis.
Well, thank you very much. We're trying. This has been uncharted times. 2020 has been such an incredible year of just challenges and strife, and we're right in the middle of additional turmoil. But today we want to talk a little bit about the response to COVID. And if we could, for the folks that may be tuning in to the first time or experienced the hospital, tell us a little bit about the difference between a community owned hospital and a for-profit hospital.
Well, it's been a kind of an interesting history with hospitals across the country, and there's been a lot of change in the last couple of decades. So when I started my career, for example, there was 135 hospitals in the state of Tennessee, and there were no health systems. And as that has evolved, you've had some for-profit systems form and buy out hospitals. You've also had not-for-profit systems like a Covenant Health system that has also acquired hospitals and formed larger systems. So what's really changed in my career here at Blount Memorial was there are now, I think, only 8 independent hospitals left in the state, and there was 135 when I started my career. So almost all hospitals have we've gone through this consolidation in the last 20 or 30 years during my career, and really the only 3 independent hospitals left between Crossville and Bristol is Sweetwater, Blount Memorial, and UT Hospital.
Wow.
The only independent hospitals left.
So Don, let me ask you, why is it such a challenge for a community-based hospital to compete in that environment? Is it because the system can spread costs out further than a community that's based just on that county or in that service area? Talk a little bit about that.
Yeah, it's a combination of things. There's something in reimbursement in this country where Medicare adjusts their payment based on your wage index. It's called an area wage index. So if average reimbursement for Medicare is 1.0, hospitals in areas with high costs like New York or California get a factor applied to that, and places that are in lower cost areas get paid less. So it was discovered 10 or 15 years ago there's a flaw in the formula, and it's created problems in the areas that are under 1.0. They continue to get lower and lower reimbursement. So states like Tennessee, Alabama, a number of states really have been kind of punished by that and get really traditionally low reimbursement. I think you've also had the cost of healthcare has gone up to try to run an organization. The cost of information systems and technology has really increased and caused issues, especially rural hospitals have had a hard time keeping up and being able to access the capital to maintain their facilities and their plant. So the first leading edge was a lot of the rural hospitals started to get bought up by bigger hospitals, bigger systems. Then you started seeing it get to larger hospitals. So even in neighboring Knoxville, when I started my career, Baptist Hospital was a great hospital, 400-bed hospital, and considered highly, and it's gone. St. Mary's Hospital was the largest hospital in Knoxville when I started my career in 1985, and it's closed down now. So you had two major hospitals that have just gone under. The other big thing has been a big push the last 20 years of trying to shift patients more to outpatient settings if you can. So as technology has improved and procedures have improved, cases that were done in a hospital 30 years ago are done outpatient typically now and go home. So that has also kind of put pressure on hospitals to have lower census in the hospitals. And the ones that weren't able to make that conversion to kind of flip their business model more to an outpatient model and less emphasis on the inpatient struggled a lot more. So to give you an example, 65% of Blount Memorial, our health system's revenue now is outpatient revenue. Only 35% is inpatient. So that traditional model of a hospital has really changed a lot. And like I said, only 1/3 of our total revenue is actually patients in the hospital on an inpatient stay, and 2/3 are outpatient. So the ones that weren't able to kind of make that shift also kind of suffered.
Wow.
Struggle.
Well, we're fortunate you guys have been able to stay ahead of the curve and be able to compete as long as you have.
Well, we have as you know, Blount County is a very proud county, and we don't think of ourselves as a little suburb of Knoxville or something. We think of ourselves as leaders, right. And that shows across this community in our education system, in our industry, in our Blount Partnership. That really stands out if you live in Blount County, you kind of recognize that. And that also translates to the hospital. So, we've got 9 board members from our community. They feel very strongly that we can better serve our community if we have a locally controlled hospital and board. And our medical staff feels the same way. We've recruited a lot of great doctors in the last 20 or 30 years here, and they could have gone anywhere they wanted to. They picked Blount County because of the lifestyle. They wanted to practice good medicine and be in a good hospital, but they also want the good education system. They want to be able to be 10 minutes away and maybe get to their kids' soccer practice. And a lot of times that doesn't happen when you work in a bigger city, in a larger system, where you may be rounding at 3 different hospitals and not be able to have that quality of life that you can have here. So we've got doctors, we've got a board that both feel strongly that we don't want to be a subsidiary of some big system somewhere that's where the decisions are being made in Nashville or Knoxville or somewhere else. So that's really kept that kind of a fierce feeling of maintaining our independence and maintaining us being an independent Blount County hospital. So we've really worked hard at that. It's also helped us that Blount County has been a growing, prosperous county with low unemployment and new jobs and the population going up. So when you're being pressured on the reimbursement side to get paid less for things, but the population is growing, it's kind of offsetting some of that. If you're in county where you've got stagnant population and stagnant jobs and reimbursements going down, it's just inevitable that they're going to end up going out of business or they're going to be gobbled up by somebody. So that's helped Blount Memorial too.
That's great. Talking a little bit about that fierce independence and the decision making being made here local versus somewhere else. Let's talk a little bit about COVID. And as we saw COVID come over from China, it started manifesting itself in Seattle and moved across the country into bigger populations like New York, and then started coming toward Tennessee. Kind of relive for us or talk to us about how the hospital reacted and when you reacted and how you reacted, if you would.
Well, we were obviously monitoring it very early on, and we have, as you know, we announced last year, became part of the Mayo Clinic Care Network. So we also were in regular conversations with Mayo, and we were trying to stay close with them. We were obviously monitoring and following things like CDC and watching those guidelines come out, but we were staying in lockstep with Mayo, what they were doing. For example, really starting in January, February, Mayo Clinic was already putting in travel restrictions for their employees and starting to prepare some of those things. And we kind of matched those at the same time they were doing it. They were kind of ahead of the curve, even to CDC and some of those other guidelines. They were putting precautions in place and preparing. So we were kind of following that and beginning our preparations in January, February. Then we initiated our incident command, which is part of our kind of emergency operations plans. And all hospitals have to have this. So through our accreditation, we always have to have kind of disaster plans in place for what you would do if there was a plane wreck or a pandemic or a fire or a hurricane or whatever. So we have those kind of things in place, and it's just a matter of activating it. So we activated it very early and had our incident command, which kind of follows FEMA organizational policy on how you set up incident command. And for example, you got section chiefs in charge of supplies, in charge of your workforce, in charge of monitoring those things daily. So we kind of got on the leading edge of that. We decided early on, from what we were seeing across the country, that the outbreaks were occurring in high dense areas, and you had these hot spots popping up. And a lot of the PPE and a lot of the resources were being kind of focused and directed towards those areas. And we were a little concerned on the front end of being in Blount County and not being on a leading edge hotspot, that we were going to be disadvantaged in terms of being able to access ventilators and PPE and all those kinds of things. So we kind of started very early. We wanted to, number one, I think we were the first ones in the area to set up testing drive-through tents. So we had testing centers set up several weeks before Knoxville and some other places had them set up. And we just felt like we couldn't wait for the state to be able to mobilize, because we knew once the state mobilized, they were going to focus on Nashville and Memphis, where they were having their breakouts. And places like Blount County were going to be down on the priority list. So, testing is key to be able to have any chance of being able to isolate people and getting them tested early to kind of prevent that spread. So we really focused on getting that set up. We're focused on access to testing. So, right now, for example, we have 3 different sources that we're using. We have an in-house test and a couple of other national labs and a regional lab that we use, and we can kind of use and alternate between those depending on turnaround times and what supplies we have and things like that. So we thought that was key on the front end. And then we started obviously all the planning around where would we place patients, how would we isolate patients, how do we keep patients, how do we keep sick COVID patients out of our clinics and the hospital, nursing home, and all that. So one of the reasons for setting the tent up outside is to keep people from coming inside the clinic and infecting other people while we're testing them. Same theory behind why we set the triage tent up in front of the emergency department, because people with respiratory illness can go right in the tent. We can test them out there, treat them out there without having them actually come in the hospital. We had to put in restrictions for visitation. We had to significantly lock down our nursing home, our skilled care facility at TCC and Morning View Village, and also put restrictions in place for the hospital, again, to try to keep those asymptomatic people out and try to keep our employees safe, keep our patients safe, and get patients the right care they needed. So it's really been a whirlwind. Been a lot of preparation. I'm really proud of our group. We've really been ahead of the game, and there's been pretty much daily meetings and conversations for the last 3 or 4 months dealing with this and staying on top of it, staying on top of what Mayo's doing, and making sure we're kind of a leader there. And so we're really proud of our folks for all the work that's gone into it. We kind of had a theme when we instituted incident command, our kind of emergency operations group that was meeting daily, kind of started early on that we're going to be prepared and not panicked, and kind of continue with that message throughout with our workforce and with our medical staff and board, that we're going to be here to take care of this, and we need to be prepared and not just panic about it. And we've kind of kept our heads, and really proud of our folks for being cool as cucumbers through all this.
So let me ask you a little bit about what you said there. How many test locations did you have during the height of the COVID?
Well, we set our drive-through testing center up over at ETMG in the parking lot in Alcoa, and that was our primary site. Most of the community people, when they would call, we would tell people to call in. We would kind of screen them, and we would advise them to go through the testing center. We also had the capability of testing people like in the emergency room, in the hospital, and some of our clinics, and some were done there, but the vast majority of our tests that we've done were through the drive-through testing center. We've done to date about 4,500 tests. And I kind of might point out for those people who look at the State Department report that comes out every day, it'll show how many deaths, how many tested positive, how many recovered, and how many tests have done. What gets put on that report is what tests were done by the state. It's not showing the total number of tests, because we've done 4,500, and you would add 4,500 to that list to see how many really been tested in Blount County.
Okay.
So that's kind of a point of clarification there.
So have the tests improved that you have access to now? Like, we would see images first when the tests are being done, and I mean a little tongue in cheek here, but they would use a broom that would go to the back of your throat to swab, and then you would see those folks. Have the test kits improved at all?
Well, again, I'm going to reference Mayo Clinic. So when Mayo Clinic was early, they were one of the earliest ones to actually validate the different testing methods of how to do it. And clearly the swab up your nose and the back of the nasopharynx area is able to capture the most viral load. So there's more concentration there. It's possible to swab the back of your throat, and it's possible to do other types of testing, but the most accurate is the one in the nasopharynx area. It captures the most. It's a much higher percentage of the viral load that you're trying to capture to test. So that's really the cutting edge best way to do it. The other testing or the other ways of obtaining samples are just, they don't get as much material, they're not as accurate, and haven't been validated as being as accurate.
Okay.
And what I will say is improved dramatically is very early on, our first access to a test was through a company called LabCorp. And what happened very early on, we were testing a lot of people. There was about 100 cars a day coming through our testing center when we first opened. And LabCorp just got overwhelmed because people were sending them tests. And what started off being a 4 or 5 day turnaround peaked at almost a 10-day turnaround to get results. So people are having to be quarantined at home waiting for results for 10 days or longer. So fortunately, pretty early on, we're able to work a deal out with, there's a lab in Knoxville called Integrity Labs. They were able to set up a lab and get FDA approval for their test. And we've pretty much experienced 24 to 48 hour turnaround with them, and had good results using that group. And then about a month ago, we were able to get our own platform set up in the hospital laboratory, which has about a 2 hour turnaround. So right now we're kind of using, depending on how critical it is. For example, our in-house lab that does the 2 hour turnaround time, we're mainly using people that come in the emergency room, or a suspected inpatient or a suspected employee. We're trying to conserve that resource for those that it's really important to get a quick turnaround time. And the community screening ones, we are still using the Integrity Lab, which has the 1 to 2 day turnaround. And that way we're kind of spreading out our test, and we're trying to not overwhelm any single source.
Right.
So we can maintain that good turnaround and the supplies.
Yeah, that's really smart. Along those lines, you had mentioned with having the testing location there outside of ETMG, I can express from personal experience that a family member of mine's employees had, or coworkers, I should say, had been sick for a while and had went to facilities at surrounding hospital facilities and were told they weren't sick enough to be tested yet. And you all were allowing folks from outside the area come in and receive testing, which that person who got tested, I'm very familiar with, turned out they had COVID and were then quarantined. Have you all seen an influx because of the accessibility that you all provide the community of surrounding citizens trying to find out if they've got COVID or not?
I would say early on we had more, and like I said earlier, we had our testing center set up about 3 weeks before Knoxville had any set up. So there was more of that early on, just because we were one of the first testing sites up and running. So we had some of that. We also had earlier, we had pretty strict CDC guidelines about what symptoms you had to be on testing, because they were trying to conserve tests. There wasn't enough tests to test everybody, so they were trying to conserve it for people with symptoms. But we did have some of that early on in those first few weeks. But after about 3 or 4 weeks of having ours set up, Knoxville had a center set up, I think, at the zoo. The state started to get more resources for testing and started disseminating that out and allowing their health departments across the state to begin testing.
Right.
And as you've seen lately, they've even been trying to do community-wide testing, even if you didn't have symptoms. They're trying to test as many people as possible. That kind of, as more testing has gotten available across the state, we've had a lot less of that. But in those early weeks when we were set up and there wasn't anybody really testing, we were getting some from outside counties coming into our testing center. And our position was we're testing anybody that met the criteria.
Thank you. I'm going to take a moment of pause here and let those that have logged in, if you have any questions you'd like to ask, feel free to write those in the chat box as we continue our discussion here. Let me ask you, you had mentioned earlier how the hospital had to change its admission policies or admissions of the general public through and that sort of thing, and that extended to nursing homes. Are nursing homes still under some sort of quarantine that you all work with and that sort of thing?
Absolutely. It's the nursing homes are probably the single most fragile link in the chain, if you will. If you've seen the nursing home in Athens that went over in Middle Tennessee, I've got personal experience. I've got an aunt that's in a nursing home in Virginia that's had an outbreak, and when the outbreak hits, it just flies through those centers, and it happens so fast. Once it hits, it's almost too fast to react to it. So it can be devastating. So very early on, we just completely locked down our skilled care facility and our assisted living center at Morning View. Pretty much locked it down to visitors. Began very early on. Every employee gets tested twice a day for temperature and for symptoms. If they have any symptoms, they have to quarantine. We've got strict travel bans. If you leave East Tennessee and you work at the nursing home, you've either got to be tested negative before you can go back to work, or you have to quarantine before you go back to work. And we've continued that. That continues today, and it probably will continue in the foreseeable future, because we've got to protect that population. If it gets into the center, then we've got contingency plans. If we test somebody positive, we're going to be probably pulling that patient out, bringing them back to the hospital to try to get them out. Obviously, if you have a widespread infection in there, you have to come up with plans to isolate in certain areas of the building to try to isolate it, keep it from spreading. But we've been very aggressive on the front end with our nursing facilities and our Morning View Village. Even more so than the hospital. I mean, the hospital still has visitation restrictions. We're doing temperature checks at the door. We're only allowing one. They can have 2 visitors, but only one at a time. And we kind of have everybody going in one entrance and screening them, putting a badge on them to let them know that they're approved and have their temperature taken. So really been aggressive at the hospital, even more aggressive up at TCC in Morning View Village.
So with all this testing that's going on, we're also hearing testing for antibodies to try to identify folks that have had it.
Right.
Or are you all doing any of that sort of testing?
We are not doing that yet. We have one of our vendors that we work at with in our lab has one of the FDA approved antibody tests. What they were telling us early on was all of their supplies were going to hotspot areas, and that it would be a while before we would be able to get the supplies and the reagents necessary to run the test. We anticipate pretty soon being able to have that. I'll kind of throw out a word of caution though. What I'm hearing from some of our physicians and even some of the ones in Mayo Clinic is there's a lot of question marks about the reliability of the antibody tests that are out there, how accurate they are. I've even seen articles that say they're only 50% accurate. Wow. And they're unclear about if you test positive for the antibodies, they're still clear. Even Dr. Fauci will say, we don't really know what that means. We're not sure. We think it means that you probably have immunity, but we don't know how much or how long that lasts. So there's still a lot of question marks about the antibody tests. And so I just kind of throw that out. We anticipate having that test available in the near future. We're not 100% sure how reliable it is or what to do with that information, what that really means if you test with.
So we're talking a little bit about access. Do you all have access to any of the experimental treatments or anything, any processes or anything different to treat this disease?
Well, the two right now, the two things right now that are approved and that are out there are the remdesivir. Each state has gotten a certain allotment of that, and each state is kind of in charge of doling it out. So right now we've had a couple patients that you have to kind of go through a process of taking your case to the state, and they decide whether they'll send you a dose or a treatment series of remdesivir. And we've had a couple of those. Probably the most exciting one is very early on, Mayo Clinic developed their the plasma treatment, where they basically take donations of people who have had COVID and recovered, and basically they spin down their platelets, which has the antibodies in it, and then give those antibodies to patients with COVID to try to help them. So that started really at the very beginning. Matter of fact, I think our very first patient at Blount County was one of the first ones to go over to Medic and donate blood. So every region has a blood center. So everybody in our region who is recovered from COVID are being asked by their doctors to please go to Medic and donate blood so they can develop, spin down their platelets. And then the hospitals that are part of the Mayo Clinic trial, basically you kind of go through an approval process and get approval, and then you're able to give the dose. So our very first one, and again, on terms of limited supplies, I'll say this. Right now, all those treatments that are out there, they're really only allowing it for the sickest patients because they're trying to conserve how much they have. There's not enough supply yet to broadly use it. So they're limiting to that. So our very first patient that got it, and was a patient in our hospital, and she was really sick, and it was really near she was kind of at a bad spot, about ready to go on a ventilator. Wow. And we were able to get the plasma, give her the plasma. I think gave it to her on a Friday night, and our doctors say they were completely amazed that they have x-rays from her lungs from Friday, and within 24 hours her lungs were looking clear.
Wow.
And, she got moved out of the ICU to the regular floor within 3 or 4 days, and was discharged a few days later and walked out of here. So that was really exciting to be. I believe we were the first in the area that had one of those. Now, a lot of hospitals have joined that trial. So I believe Covenant and UT or both have joined that Mayo Clinic trial, and they have access to that too. I think they've gotten some doses of that also. But those are probably the two things that are the most, I guess, encouraging is the plasma treatment and the remdesivir. And we have access to both. We've used both. It's looking like, from what I'm hearing, the earlier you can treat somebody with it, the better a chance. So one of the frustrating things is because of limited supply, they're limiting it to people that are really far along and are the sickest patients. And I'm not sure. We're going to certainly find out as the trials go forward about how effective is it when you give it late versus giving it early to preventing it.
So let me ask you along those lines, how long does it take for an approval process to treat someone with the plasma? How long does it usually take to get that?
We had it done within probably 2 or 3 hours.
Oh, wow. Okay.
Once we got on the phone and we presented the case and all that, they approved it, and we were able to get it from Medic, and it was a matter of hours from the time we started to the time we were given the plasma treatment.
Wow. Yeah, along those lines, I had one of our folks that logged in had just said, thank you for Blount Memorial team for your leadership to provide excellent health care for the county as well as the region. So a nice accolade there from some of our viewers.
Well, we appreciate that.
Let me ask you, Don, what changes have you had to do to the operations of the hospital from, we've seen a curtailment of elective surgeries to kind of a ranking of the different needs a hospital normally provides. Talk to us a little bit about how your business model's changed.
Well, it's been a whirlwind, and I think it's one of the observations I've kind of noticed through this when it first hit and you had these shutdowns is there's businesses out there that are essential services that have been slammed. I think of things like grocery stores and things like that. They've been slammed through this process. And then you have businesses that were completely shut down and pretty much out of business while the shutdown was going on. And a lot of them are in the process of trying to reopen and recover. We're kind of right in the middle because we were an essential service. We had to be here. We had to be prepared. We're kind of the front line of this. But at the same time, the governor shut down all elective cases. The purpose of that was to try to conserve PPE. We were worried about a surge of COVID patients and that we would run out of masks and run out of gowns and all that. So the purpose for shutting down elective cases wasn't because it was a high-risk area like a restaurant or a concert. It was to shut it down so you could conserve masks and gowns and things like that, PPE. So it was pretty devastating to us because, like I said earlier, 2/3 of our business is outpatient. So we had overnight half of our business shut down in terms of revenue coming in the door and the business we do. But we were spending a lot of money and resources and energy trying to prepare for the potential surge and prepare and beef up our supplies and do our training and cross-training and all those things we were having to do. So it was really, it was a pretty amazing transformation overnight that we went, and by doing the lockdown and having half our business shut down, it was, and the surge never really happened to the degree that some they were worried about on the front end. I think at the most at any given time, we might have had 4 or 5 patients in the hospital and a few suspected.
Oh, wow.
So we had a half-empty hospital and an empty surgery center and all that going on, and all the revenue hit from that. And at the same time, trying to prepare. So it was pretty dramatic.
Wow.
Now, I'll also say it's been a pretty dramatic recovery. So, on May 1st, when they started opening back up, we actually had about 1,500 cases in the backlog that had been, stopped because of the shutdown. And we had doctors and staff started working Friday, worked all through the weekend trying to catch up with the backlog and trying to get those patients back in the pipeline. So it's been a dramatic roller coaster, really. It went from super busy to half our business shut down to trying to ramp back up and get all that going back again. And it's been pretty dramatic.
So have you had, with that whole shift from where it really sounds like your profit margins were of these surgeries and performance, and having to shut that off. Have you had any employment challenges, or is there any challenges to hiring folks that you need, or talk a little bit about that?
Well, even though half our business was gone, we're pretty proud of how we handled it. Nobody lost their job. We actually created a labor pool, and all the people that were in areas that were closed put their name in a labor pool if they wanted to continue to work. Now, some people used PTO and stayed home. A lot of people put their name in the labor pool, and we actually got busy setting up production lines and started producing our own PPE. We had 65 employees at one time in a production line going, and we ended up that production over a course of a month or so. We produced 30,000 gowns and 8,000 N95 masks through our employees. Basically setting up production, we were able to get supplies and just start making our own, creating our own PPE to have as our background. We also came up with some creative stuff for our employees. We allowed employees that were working could donate PTO days to the ones that were not working, or that were in an area that was closed. We are able to defer some of their benefit cost if somebody did go home and was not working, and be able to put off some of their benefit costs, like their health insurance premiums, things like that, to a later date. Kind of a combination of all those things. We want to be able to keep people on the payroll, and we want to keep people with their benefits and an opportunity to do that. So that labor pool that I talked about opened up immediately when we went into shutdown of elective cases. And we actually still today have some. The labor pool was redeployed to the front entrances, taking temperatures. They were delivering supplies and food around the building. They were creating PPE. We had 4 locations in our building where we had production lines going, where we were making gowns and making N95 masks.
Wow.
So we were able to keep most people employed and going, and the ones that we couldn't keep employed were still on the payroll and using PTO and things like that.
Well, it really sounds like the hospital came together at a moment of challenge, and really pulled together to make sure our community was taken care of. And I know that we all thank your staff for doing that.
Well, the other thing we did is during some of those downtimes, we worked on cross-training people that were in other areas that maybe were closed, and cross-train to be able to take care of COVID patients if we were to get a surge, or if we were to get a surge again this winter. We had doctors cross-training, and we had nurses cross-train, respiratory therapists that maybe normally don't work in a unit or work with an ICU patient on a ventilator, to try to make sure that we were prepared. If one of the things that happened in New York early on was when the influx hit some of those hospitals, you had up at times 30 and 40% of their workforce had it and were home quarantined. So they were trying to run the hospital with 30 or 40% fewer employees. You had people working 24 hours. You had people.
Wow.
So we kind of decided early on, we wanted to cross-train people to be able to, if we were to have a group of our doctors, for example, have to go out and be quarantined, then we had other doctors that could step in and manage ventilators and manage ICUs. And same way with our nursing staff. We want to be prepared for that if we had a group of our employees or staff that couldn't work.
So we're talking about training there. Talk to us a little bit about how the hospital and the doctors are kept up to speed with the latest treatments or quarantine procedures. How do you all get, because this is an ever changing dynamic going on of how we're treating these patients. Talk to us a little bit about how information is coming to you all.
It's pretty much daily. We get guidance from CDC, we get guidance from Mayo Clinic, and we get a lot of that information and basically updating it on a daily basis. We also have regular calls where our medical director has calls with our medical staff where they can log in, and we talk about everything that's going on and what the latest is, and so they're staying up on it pretty much daily, and it's changed daily. As you've known, there was
That's right.
this pandemic. What stood out to me that's so fascinating is if you think about how it started in China and spread to Europe and spread to the United States, you've pretty much had the very best medical minds all over the world, China and Europe and the United States. And this thing has stumped everybody from the beginning. It seems like there's something new almost every day where, one day it's not going to spread, the next day it is going to spread, and the next day you should wear a mask, and one day you shouldn't wear a mask, and this drug works and that drug doesn't work now. And it's been fascinating to watch this. It's kind of, from all the models, there was seen more models than I've ever seen before being put out there, and they were all putting out different predictions, and it was all scary. But it's been interesting. It's been this interesting ride where it seems like this thing has stumped a lot of people, some of the very best minds in the world, and it's kind of evolved day to day as we learn more and more about it. So that's been interesting. And so it's been critical for our physicians, our medical staff leaders have had to pretty much on a daily basis stay in touch with CDC and Mayo Clinic on whatever the latest, best treatment is and how we should go about running the hospital.
Now we're getting close on time. Let me ask one kind of final thought from you. I know you don't have a crystal ball, no one does with this pandemic, but what's your thoughts on the fall? I know that there's discussions of maybe there's going to be a second surge. There's really optimism with a vaccine or more medications coming forward toward the end of fall to treat this disease or prevent the disease. Tell us a little bit about your thoughts. And again, this is such a fluid situation, but we'd really like to know what you think moving forward.
Well, kind of like I said from the beginning, our theme has been prepare to not panic. So we've put a lot of thought. There's a lot of discussion about what might come in the fall, and nobody knows for sure, but there are some indications. If you look at other respiratory illnesses, they do tend to be worse in the winter, fall and winter, than they are in the summer. Oftentimes with the seasonal flu, the CDC looks to the southern hemisphere to see what kind of flu season you're going to have and see what kind of flu formula you're going to have. And what I'll tell you is right now in the southern hemisphere, they're going into fall and winter when we're going into spring and summer.
Right.
So what you're seeing in the southern hemisphere is the coronavirus is spiking there. They're having pretty significant spikes in Brazil and in some of those places. So that could be an indication or kind of a forewarning of what we might see here and see a spike starting in the fall and the winter. You're probably going to have kids back in school, and you're going to have respiratory illnesses start to spike with colds and the regular flu, plus the potential for COVID-19 coming. So our incident command folks are kind of preparing for what happens if we have flu and the normal pneumonia season, and then you've got COVID-19 spiking in the fall and winter at the same time. So we're making preparations now for that. And certainly it would be fantastic if one of these drugs come out and it's a wonder drug and we're able to distribute it. That would be the best case scenario would be for us to over prepare and not have to implement any of that, but we're preparing for it. So we're doing things like we're looking ahead and where we can, we're going to be building up our inventory of PPE going into the fall. We don't want to get caught in the winter and have a spike and all of a sudden be in the same situation where we don't have enough. We're working on continuing to develop our testing capability and testing supplies going into the fall. So over the next few months, we're going to be trying to build up supplies and build up our testing capability. So if it does have a big spike, that we won't be behind the curve. We'll be able to kind of hit the ground running. And we're making contingency plans for reopening the tent we set up in front of the emergency department. We're taking down because we have low volume right now, but we kind of have a contingency plan for reactivating that if we were to start to see a spike again in the fall. Really, the best predictions I've seen on vaccine, it's still questionable whether we're going to have one or not. If we do have it, the best case scenario I've heard is possibly in October-ish. They might have enough to give vaccines to frontline workers and healthcare workers, and then maybe by January, February, they would have enough to start vaccinating the general public. That would be great if that happens. The one thing I would say to everybody in the community, and we're really going to push this hard this year, we really need a great penetration of flu vaccine this year. I know there's lots of controversy at times with folks about getting vaccines or not, and there's that whole other side discussion about that. But the flu vaccine, even in years when the formula is not perfect, it still helps prevent, it boosts people's immune system and helps prevent the spread of flu. And why it's so important this year is every fall and winter we have a flu season and we have a pneumonia season. But if we also have a COVID-19 spike on top of that, that's really going to stretch resources if you have a bad flu season and you have a bad COVID-19 season. Those two things combined would not be good. And this spring, this outbreak in March and April that we've seen is really the tail end of regular flu season. So regular flu season and pneumonia was tailing off about the time COVID was coming in to our country. Excuse me. That won't be the case this fall and winter. We'll be going into flu season and into pneumonia season. So we're really going to be doing everything we can to encourage the community to get the flu vaccine. Even if you don't like it, this year you ought to get the flu vaccine, because if we can help keep the flu knocked down, that kind of helps us with capacity. If we do have a COVID-19 outbreak or a spike, that we'll be able to better take care of that.
Along those lines, a question that I've heard kind of talk behind closed doors, if you will, and I'll just ask it. When you look at and we are in an anomaly here in East Tennessee, but have you seen more of a devastating effect related to COVID versus the general flu or pneumonia as it relates to mortality or severe complications?
I can't say that we have here. We've been very blessed in Blount County to have a relatively low number of cases. The ones that get sick enough to get to the point of needing a ventilator, or at that point, their recovery rates are just very low. It's really devastating. But you got a large majority of people who have very mild symptoms or no symptoms, or it just seems like a normal flu or a normal cold. So certainly, if you look back at this last year, we had more flu cases than we've had COVID patients, for sure. And I hope that bodes well for us in the future, because there's definitely a correlation with population density. If you look at where the worst outbreaks are, it's definitely, even in the state of Tennessee, you look at Nashville and Memphis, if you look at the number of people per square mile in those two counties, it's, probably 20, 30 times the number of people per square mile in Blount County or in Knoxville or the rest of the state. And that's where the outbreak's been. So there definitely seems to be a distinct correlation of population density to the spread of this. But I don't want our community to be lax about that either, because it is there, and it's still there, and it spreads easily. And I worry sometimes that it hadn't been as bad as we thought it was going to be. So people are I'm seeing people not using precautions and kind of being lax about all that. And I think it's still important. I encourage our employees to set a good example when they're out in the community about wearing masks and keeping the social distancing and washing your hands and all those things. It's still important. And we can have it here too. It probably it won't spread as fast as a high density population like Nashville would, but you can still have spread and it can still be devastating to people.
Right. Well, we've been very blessed in Blount County with the natural beauty, and then just in where we're at, we kind of social distance because we aren't those urban populated centers that we were discussing about. So a lot of blessing for this community. Well, Don, you've been very generous with your time. Appreciate you joining us today, and keep up the good work with the hospital. And I know that I speak with the business community and the citizens if there's any way that we can help with the hospital. And as we move toward the fall, I'm sure there's several of us that would step up and try to help. So thank you very much for you and your team.
Well, I want to make a kind of a plug for our community because I've mentioned to several people before and several groups of people. I have a very young workforce. So when the economy got shut down, schools got shut down, I've got a lot of employees here who had kids at home, and they're working 12-hour shifts up here at the hospital on the front lines. And they're stressed and they're worried about taking COVID home to their families. They're worried about their kids being at home by themselves and whether they're really online doing their homework like they're supposed to be. So it was a very stressful time. And we've been so blessed by community donations of PPE, community donations of food and meals bringing to people. We had Denso set up a production line and produce 8,000 face shields. We had Maryville College producing face shields and letting our staff use their apartments. So our employees who are taking care of COVID patients don't have to go home and infect their family. They have a place to go to stay and kind of quarantine while they're in that process. So it's just been such a morale booster to see prayer circles out in front of the hospital and meals and PPE donations and people sewing masks and making shields. And it's been such a blessing and morale booster. I just want to, I feel so blessed to live in a community like that steps up and supports our people. And it's been fantastic.
Well, thank you, Don. And before we sign off, we've had other folks here expressing their adulation for the hospital and your efforts and leadership. So this recording will be available on our social media outlets. So those that would like to replay it, you will have the opportunity to do so. Without anything else, Don, thank you again for today, and we bid everyone farewell. Thank you and have a great day.
Thank you.